Good afternoon, everyone. I'm Chris Sorchik, the Executive Director with Capital Area Healthy Start Coalition. I want to thank you for joining us this beautiful Friday afternoon. We are continuing our Lunch and Learn series today with a topic that I know I'm excited to hear more about. We do ask that if you are not speaking to please put yourself on mute as we are recording this Lunch and Learn session. Access to care was identified as one of our key priority areas when we wrote our coalition's 5-year service delivery plan. And the Access to Care work group members identified a need to provide education to the community on not only the importance of early entrance into prenatal care, but also what quality prenatal care looks like, and what options are available for women when it comes to their prenatal care. In today's presentation, we're going to hear about the midwifery care as an option for prenatal care. If you have any questions during the presentation, if you would please put those in the chat, and we're going to answer the questions at the end of the presentation today. Please welcome me in joining our presenter, Tiffany Austin. Miss Austin has nearly 20 years of experience in traditional African dance techniques, rhythms, and educational facilitation. She meets her students where they are in their knowledge and skill, and has a keen eye for technique and nuances of cultures from various West African countries. She has an exceptional ability to work with children, including those with special needs, leveraging her ability to independently and collaboratively develop curriculum infused with African cultures. Ms. Austin is the Executive Director for Fertile Ground Family Services, Inc., a 501c3 nonprofit organization whose mission is to improve the physical, social, and psychological health of families by providing remote and in-person access and community solutions through outreach, public panel discussion groups, evidence-based education, and wellness services in the areas of parenting, family sustainability, childhood development, and healthy life patterns. Ms. Austin delivers lectures in an engaging fashion and is able to provide positive critique and aesthetic input. She is able to receive direction and guidance from collaborators and has a genuine enthusiasm for the creative process. Her motivation stems from a deep connection with African culture and quest to seek and share knowledge in every endeavor in every person. Good afternoon, Tiffany, and thank you so much for being with us today.
Thank you, Chris. I appreciate your having me today. And it's an honor and an absolute privilege to present on something that's very near and dear to me. Midwifery care is something that I was fortunate enough to have with both of my pregnancies. I have a 19-year-old and a 14-year-old, and my midwives took good care of me the entire time. So in my introduction, of course, I wear a lot of hats. I didn't know that we were starting with the West African culture and dance, but absolutely, when I'm not a midwife, I am engaged in all sorts of things. So today we will be talking about the midwifery model of care. So what is that exactly? So the midwifery model of care, it views pregnancy and birth as normal life events. Where there's life, there is often this complementarity aspect of life and death. So midwives also kind of, we acknowledge that life, however it may occur, however it comes, is a very natural event. We offer personalized care and build relationships with our clients. We also emphasize the physical, emotional, and social well-being of our mother, the baby, and oftentimes the entire family. As a midwife, I find myself in many roles as counselor, as parent educator, My first background is early childhood education. So a lot of those topics, especially with my families, with multiple children, I get to kind of help steer them in a positive direction for parenting. So in our little thought bubble here, these are sort of some beliefs that are pretty general amongst midwives. So birth is a holistic process. We believe in the integrity of birth. The experience of pregnancy, birth, and loss are life-transforming events. There is no class distinction between birthing person and the caregiver. So I would say that this is probably one of the benefits to midwifery care. My clients, they view me as a human. I'm not this authoritative figure who is dictating their pregnancy journey and labor and delivery. I am a partner helping them to receive the best outcome possible. So, and then information is shared with an attitude of personal caring. So the history of midwifery in Florida. So we're just, midwives have been around for eons, but we started at 1930 because that's kind of when the changes began in Florida. At that time, there were about 4,000 midwives serving families. And in 1931, the state of Florida passed its first midwifery licensing law. And at that time, 1,400 of the 4,000 became licensed. In 1933, Florida Midwife Manual was written for licensed lay midwives, and Florida began offering classes at the Midwife Institute established at Florida A&M College, now known as Florida A&M University. Go Rattlers. And the Institute held other midwifery trainings regionally in cities such as Tampa and St. Augustine. So this was a big shift in the history of midwifery. Most of the midwives worked in rural areas. They cared for Miccosukee, Seminole, and many rural white residents. So with the passing of this law, it became a little bit of a barrier because many of the midwives at the time were elderly or older, and were actually referred to as granny midwives. The term has now been changed to grand midwives to just give a little bit more honor to the women that paved the way. So these grand midwives, of course, many of them were not able to read this manual, and that eliminated them as practicing midwives. So what is midwifery? This is from our Florida Statute 467. If there's anything that you will write down or take away from this presentation, I would encourage you to go to our statutes on midwifery and just read up on what it is comprised of. So licensed midwives in Florida, we follow the law. Midwifery means the practice of supervising the conduct of a normal labor and childbirth with the informed consent of the parent. It's the practice of advising the parents as to the progress of the childbirth and the practice of rendering prenatal and postpartum care. So as a midwife, I am a continuous autonomous provider for a client. That client only sees me for her pregnancy, except for her 20-week anatomy scan, which we'll talk about. So we start prenatally and we move through labor and delivery, and we move through postpartum, and then we have our sad 6-week visit. Okay, the benefits of midwifery model of care. So longer, more in-depth prenatal visits. Most prenatal visits are an hour. Realistically, they're more like an hour-ish, hour and a half. That in itself is another benefit of midwifery care. The visits are often in your home or in a familiar surrounding or environment. And these visits are, midwifery is heavy on education and counseling. Our main goal is to keep you low risk, remaining low risk. We want to get to the finish line of or safe dates, or no longer being preterm. We want to get you to your safe dates, your safe window, a full-term baby, and then a home birth. So, of course, individualized care and attention. Each pregnancy, each fetus, each situation is different. So while there are many common aspects of pregnancy and labor and delivery, many common complications, many common discomforts of pregnancy, lots of things are common. So one approach that I take is to educate first, because a lot of times this is a very unknown process that the family's going through. So education is like big. Once you get them to understand that this is actually a normal occurrence, and how you can kind of mitigate them, it works pretty well for my clients that listen. Lower rates of cesarean sections and other medical interventions. And I will say that I was not able to find the time to get any data on this, but it is absolutely out there. Shared decision-making between caregivers and birthing person. So on the previous slide, you saw informed consent. So what that means, I tell my clients that my job is to give you the information, give you the evidence-based information, educate you on why we do a certain thing, why we're doing this lab, why we need to transfer out of care now. My job is to educate and make sure that they understand what low risk is versus variation of normal versus we need to transfer care to the medical model. All right, and let's see about this medical model. Okay, so what are the differences? So doctors are trained to manage high-risk pregnancies and complications that require medical intervention. High risk. Licensed midwives care for low-risk patients. We care for low-risk patients, and sometimes we can also collaborate with the physician to continue prenatal care with that client. Obstetricians perform surgeries. This is the main difference. If I would say anything, this is the main difference between an obstetrician and a midwife. As far as the care schedule that a patient gets during pregnancy and labor and delivery, a normal low risk, we're talking normal low risk, as far as that care that's received, it's exactly the same. Obstetricians, childbirth is potentially a pathological process. Midwives don't start with that. It's just not in our our DNA. However, we do recognize the pathological process because we see normal so very often. We're able to recognize when something is getting outside of normal, but we don't start there. Birth is a work for doctors, nurses, midwives, and other experts. Where's the patient in that? Where's the baby? There's often this well, I'll speak personally. Anytime I need to go into a medical facility, it's like, what are they going to do to me? What are they going to, if it's this feeling of what's going to be done. The woman is a patient. often a class distinction between obstetricians and patients. Again, that kind of authoritative or submissive, dominant feeling. Our patient here does not look happy, does she? Brief, depersonalized care, information about health, disease, and degree of risk is not often not shared with the patient adequately. A lot of the clients that I will transfer over to me, I get all of the stories, just why, I want to know why you're coming to me. I want to know what made you want to seek this type of care. Why do you want a home birth? Are you sure? Do you want a home birth? Or are you just wanting prenatal care? And do you want to deliver in the hospital? So I ask these questions, and oftentimes I get the stories of why. And a very common reason is because they're just not understanding what's being done to them at this very important time in their lives. Their questions might not be answered adequately. Very common for people to not know what they've been tested for, let alone the results. So just a difference. So these are the births by delivery method for Leon County. This is 1989 to 2021. And we see that it's wonderful. We still have more vaginal births than cesareans, yay. But we see that that is declining, while we see the mirrored effect of cesareans on the increase. Now, I'm not sure what happened last year, but we had a little change there where the vaginal births increased a bit and the cesareans decreased. So I'm sure that we're still trying to figure out how the pandemic affected the outcomes of births. But this is our county of Leon. Okay, prenatal care with a licensed midwife. So prenatal care. So this is our complete care schedule. Someone reaches out, we start with a consultation. I'll kind of talk to them on the phone and briefly determine whether they may be a good home birth candidate. And then we'll have our consultation. That consultation is an hour long, and that's where we really get in depth with their risk status. And we do a risk assessment. We also do all of our initial documents. I have an electronic medical record system that I use, just as a doctor would. We have our initial prenatal visit. We have our 20-week anatomy ultrasound. That's a referral out to the radiologist. And then I see the patient, I say client, y'all. I'm struggling with the patient. I see my clients every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and then every week until delivery. And you must deliver by 41 weeks and 6 days, or at least be in labor. You must be in labor by 41 weeks and 6 days. Then we have our labor and delivery, immediate postpartum, and postpartum visits. And we'll break all this down in a bit here. So as I mentioned, the education and counseling is huge. And although I said I wasn't going to be heavy on text, first half of this presentation is heavy text. So our initial visits, we do our Healthy Start screening. We do a complete health history and gynecological history. These acronyms here, GP tells us how many times the client has been pregnant and what were those outcomes. We do obstetric history, that's OB. EDD is estimated due date. And we want to know any surgery she's had, whether gynecological or overall. We talk about lifestyle, and we do a depression screening. Also in that initial visit, physical exam, height, weight, blood pressure. I don't typically do a pelvic exam at the initial visit. If there is cause for concern or there's something that I need to assess, then absolutely. But I think that those days are kind of phasing out of just doing pelvic exams. Breast exam, I check fundal height. The fundus is the mom's uterus. Check for edema, swelling, fetal heart tones, reflexes, assess subjective symptoms of pelvic inflammatory disease, urinary tract infection, and preterm labor. Also screen for pap smears. If she hasn't had one, we'll do, now these are kind of your OB panel here. Syphilis, gonorrhea, chlamydia. We want to know her blood type, including Rh factor and antibody screenings. We do a complete blood count. We want to know if she's been vaccinated against rubella, urinalysis and urine culture, sickle cell screening for our at-risk populations, typically African-American populations, or if there's a known genetic history. Hepatitis B antigens. We want to know our HIV and AIDS status, our thyroid panel. We do vitamin D, we do vitamin B, progesterone, iron, carrier screening. This first visit, we want to talk about genetic counseling. We do any required labs. I always talk about the signs and symptoms of labor or preterm labor. Lifestyle changes or just what is the lifestyle like? What is your life like? So we can maybe address some things to give you the best outcomes. Talk about common discomforts. We start working on a birth plan, preferences, talk about neural tube defects and risk factors, danger signs of pregnancy, what to avoid, how the baby's growing. Oral health is important in pregnancy, and practice policies and infection precautions. And I can't see that last one because my name is covering it. Safe over-the-counter medications that mom can take. All right, I know that was heavy. All right, so that was the first visit. First visit is really scheduled to be an hour and a half. Now, our routine visits are typically an hour, and these are the things that are covered at every routine visit. And again, we're seeing mom every 4 weeks until 28 weeks. All right, every 2 weeks until 36 weeks, and every week until she delivers. So every visit, again, any signs and symptoms of preterm labor or UTIs. UTIs are typically asymptomatic in pregnancy, so we just screen for every appointment. I'm checking urine, I'm getting her weight, blood pressure, checking our fundal height. The WGA is weeks gestational age and size correlation. So I measure her fundus, her uterus, to make sure that it correlates with how many weeks she is. You should always measure within 2 weeks, 2 centimeters of however many weeks you are. So if you're 38 weeks, you can measure 36 or 40 centimeters, and that is totally normal. And that's kind of just a way that we keep up with baby's growth. It doesn't matter how obese or small you are. I found this to be pretty accurate. The uterus grows. It's pretty accurate, and when it's not, when the measurements are off, there's usually a reason why. And at that point, we consult or refer to maternal fetal medicine. At about 28 weeks or so, we start talking about presentation and lie. Presentation is just what is presenting at the cervix, basically. Is the baby head down, vertex, or is it a breech presentation? And the lie has to do with the correlation of the baby's occiput, the back of the head, to the mom's spine. every appointment, we're talking nutrition. I always ask, what'd you eat today? How much water have you had? Exercise. We do any labs. We talk about when to call me. Intimacy issues can present in pregnancy. I'm telling y'all, I'm a sex therapist. I'm a counselor. I'm the midwife. I love the children, the siblings, and yeah. So a lot. On any given day, I never know what what my client may present to me, or what kind of picture or text message I may wake up to in my phone. But I love it because I love that they are able to access me and get their questions answered pretty quickly. We talk about sleep. Sleep can become pretty discomforting. Any workplace hazards or workplace discomforts. Maybe she needs some leave forms filled out, some accommodations. Fears and emotions are big throughout pregnancy. We try to address those so they are kind of contained in during labor and delivery. Our anatomy scan is a time that we'll reassess the estimated due date. Hopefully that the client comes in early as soon as they find out that they're pregnant. And at that time, the earlier ultrasound or the earlier lab work is actually more accurate than this 20-week ultrasound. But at 20 weeks, we will compare data, and also here's where the baby's all vital organs, brain, heart, looking at the 4 chambers of the heart. I get to know where the placenta is. That's important for me. We know if there's any placenta previa or vasa previa. Amniotic fluid is measured. Her cervix length is measured. Lots of good stuff. So I get a report back from the radiologist, and it goes in her file. We hope that our parents get childbirth education. Travel safety sometimes comes up, when is it too late to fly? That really kind of depends on I know the airlines have policies, but, based on what her pregnancy has gone like up until that point, I may have recommendations as well. We are required to make sure that our clients have a pediatrician by 36 weeks. We talk about circumcision, postpartum plan, immunizations, postpartum support, newborn sleeping arrangements, home visit at 36 weeks if they're having a home visit, if they're having a home birth, car seat, and post-dates protocol. All right. Y'all good? Okay, so now you made it. It's 37 weeks and you're in labor. What happens? So those were my heavy text slides. So now we're just going to talk. So as far as home delivery, what it looks like is up until this time, we've had our hour visits. If you've came in around 8 to 10 weeks, you've gotten in about 10 good visits. Good prenatal care is anywhere from 10 to 14 visits. So each visit we're talking about, well, what's common question is, well, how do I know when to call you, or when do you come? So at this point, they know when to call. So they know what the signs and symptoms of labor are. We talk about Braxton Hicks contractions versus labor contractions. We talk about cervical change in the last few weeks. And I also have them download the Count the Kicks app, as well as download their contraction timer app. So when they call, it's kind of like a triage over the phone. Why do you think you're in labor? What's going on? If it's your water broke, okay, we got to get labor started. Hopefully labor starts within 24 hours. if it's just contractions, no water breaking, she's educated on when to call me. Early labor assessment is usually when the contractions are anywhere from, I'll say 5 minutes and under, or if she's needing that support and comfort. I encourage my moms to utilize whomever they can to help them through labor and delivery and their pregnancy, because it's just a big unknown. So I like to get there in active labor. When I show up, I do an initial assessment of the baby. We listen to heart tones. We get vital signs on mom. I'll do a vaginal exam. I'll offer a vaginal exam and determine her dilation. And is that it? Yeah. And then from there, we determine what stage and phase of labor she's in, essentially. I will say that everything up to pushing is stage 1 of labor. So all those stages have phases though. So essentially, what phase of this first stage is she in? And we settle in. I bring in my equipment. I do carry some life-saving medications. I have you see my O2 up here. I have oxygen. As far as anti-hemorrhagics, I carry Pitocin for hemorrhages only, not to induce a labor, and also misoprostol. Midwives can also carry Metrogen. Newborn meds include the erythromycin eye ointment. You usually see those baby with the shiny eyes. And we also do vitamin K. All right, so we're here. We literally just kind of settle in and follow mom around and get our vital signs and listen to baby as the law requires. And it may look like we're just sitting around knitting, but there's a whole chess game going on in our head, guys, when someone is in labor. Again, we know what normal looks like. So we really try our best to keep things that way, especially labor and delivery. So it's a big job, a lot to manage. I enjoy home birth. I have much more home birth experience than hospital births. My early days as a doula, I did a few hospital births and drastic difference. So yeah, home birth. Is that it? I'm trying to make sure. So we're going to move on. We love our children at births. We love our pets at births. I like to have another person on hand to take care of them if we need to, but usually children are a joy and of course curious, and it's usually the adults that are more timid and around birth and home birth. All right. Okay, so the baby came. Yay. Wonderful. All nice and normal and everybody smiling and happy and crying. Okay, so immediately postpartum. Baby comes out directly onto mom's chest. Whomever can catch the baby. We talk about it prior to, so we're prepared. But baby comes out onto mom's chest. The midwife here is assigning APGARs in minute 1 and 5. It's not said, but again, whole chess game going in my head. So there's APGARs that happen. We're making sure that the baby is transitioning well from placental breathing to lung breathing. And we are also looking in on mom to make sure that she is also transitioning well. This is a time where if labor and delivery, if delivery went well, all normal, this is the next potential time that a complication could happen. And I have to make sure as a midwife that that there's someone on watching baby, and there's someone getting mom's vital signs as well. So I do employ a birth assistant around transition period, right before second stage, right before mom is pushing, to just be there as extra hands. In the case of emergency, we may need someone to call EMS. We may need actual hands-on support. And so postpartum, immediately postpartum and before discharge, usually mom is getting her vital signs done by a birth assistant. And I like to get the newborn's vital signs. What else happens immediately postpartum? We want mom to get up eventually, not right away. She gets her golden hour for sure. Gets her golden hour. She gets her time. At home, nothing is a rush unless it's an emergency. So as far as cutting and clamping and cutting cords, that does not happen until usually after that golden hour, when I'm ready to do the first newborn exam, and we'll get to that. As far as follow-up postpartum visits, we do a 24 to 48 hour postpartum visit where we go back to the house, check on mom and baby, and also I like to offer a 1 to 2 to 3 week postpartum visit, just because this is usually a time where that postpartum, mood and anxiety things can set in. The support is left, the family member that came in town too early had to leave because you delivered later. So whatever the case is, this is kind of usually when that 1 to kind of 3 week period is where the moms may start to feel a little bit of those emotions. And then of course the 6 week visit, postpartum visit. Okay, so newborn care. So, after mom and baby get their golden hour, we call that the fourth stage. At some point, I'll want to do the newborn exam. And usually at this time is where I will clamp and cut the cord. Family member can join in, or a sibling or another child or whomever, and I guide them on that. The newborn exam is where we find out how much the baby weighs. I laugh because it's a question that comes up pretty soon after the baby comes out, and it's just funny to me. Like, we don't know, but we don't know yet. But it's done at the newborn exam. So once mom is nourished, that latch is good, placenta's out, she's not bleeding to death, postpartum bleeding is under control. She might have gotten up to go to the bathroom, as long as she can ambulate, all that. Everybody's stable now. Let's go ahead and do the newborn exam and find out how much baby weighs and get all the measurements. And so licensed midwives are the first to do the newborn exam, even before the pediatrician. A part of this exam includes, as mentioned before, the vitamin K to help baby's blood clot, and then the erythromycin ointment, which prevents infections in the baby's eyes. Also a part of the newborn exam is I'll do a post-ox reading on the baby to ensure that the baby's well oxygenated. And also a part of the newborn screening is newborn screening involves the heel prick. You may remember or may not remember, it used to be called PKU, but it's a metabolic screening. It screens for different metabolic disorders, genetic disorders within the newborn. And these are some disorders that aren't readily recognizable. So for instance, sickle cell anemia. You may not know that your baby has sickle cell anemia until their first crisis, right? So we do this at 24 to 48 hours. Stick the baby's heel, we get 5 drops of blood, we send it off to the lab in Jacksonville, and we get a report back for that. Also a part of newborn screening is the hearing test, and that's a referral. I refer out to that. I don't have the fancy equipment for that. I think that's it for the newborn, all the things that I do to and for the newborn. Of course, if there's anything abnormal, we would transfer the newborn to the hospital postpartum. We are trained to handle certain defects or complications. However, but those things are kind of set up to help us get the baby to the hospital. And those are, really odd things. I'm talking about like omphalocele or, those types of, spina bifida or those types of things. Very rare that I've seen a newborn have to transfer to the hospital. We make sure that they nurse well. Nursing is a great sign. Also, their skin color. A pink baby means that the baby's well oxygenated. A latching baby means that the baby's breathing. You can't suck and swallow if you can't breathe. So, like I said, well, it looks like we're not doing much. There's a lot, and we have to go back and chart all of this stuff. So midwives also do the birth certificate. We have 5 days, not business days, 5 days to get it in. And then, as mentioned, the family should have a pediatrician for the newborn by 36 weeks. So before a baby comes, we want that. All right, y'all, I did good. Okay. A midwife is not just a healthcare provider, but a partner who supports, educates, and empowers the whole family. She's a continuous healthcare provider throughout the myriad of pregnancy and birth journeys. That's me. I said that. And this is one of my families. I just love them. I just love being a midwife and being able to, it's such an honor to be able to enter into someone else's space and give them what they need for their pregnancy and for their, a lot of times it's a healing journey from past traumas, or it's usually a fear of medical industrial complexes. But anyone who accepts me as their midwife, I'm greatly honored to hold this title, and I hope that I am able to make a great change, maybe not in the number of babies that I deliver, but there's definitely a huge shift that would be beneficial to our maternal healthcare system. So I will take questions now. I think that's it. There's my references. That's how you find me. prayerfully this year, I will have a website. But you can absolutely find me online. Google me. If you spell my name right, you can find me, or by Fertile Ground Midwifery um, at gmail.com, or on Facebook or Instagram. Thank you all for sharing your lunch with me here. All right, I'm going to stop sharing, and I'll take any questions now.
Thank you, Tiffany. That was a wonderful presentation. Does anybody have any questions? Go ahead and come off mute.
I have a question. Thank you. That was really good. Good, very in depth, great information, and I really think midwifery is just a value to our communities. So my question is, in your experience, um, I'm sure there are people that are curious
Mhm.
about home birthing, and are maybe have not had the experience, or do not know anyone that has had a home birth when they come to you. So what can you just share, like, what are some of the reasons that people do have a home birth, and the reasons why they don't? Some of them. I'm sure you probably can't get into the full myriad, but I'm just interested to know
A lot
kind
of
of what, yeah,
mhm.
what that is in our community.
A lot of people feel like they are not being heard. um, just that's it. They just feel like they're not being heard. They're showing up to these their medical appointments, and the visits are short. They have questions, and those questions aren't being answered. Um, some people feel like they're just kind of like being kind of pushed through the meal, kind of pushed through the meal. That's usually kind of the overall reason. Now, I did become a midwife in the middle of a pandemic. So in 2020, I've been practicing for going on 3 years now. In 2020, the pandemic was the reason, of course. No one wanted to go into a hospital to deliver their baby and potentially infect their newborn or themselves. So that was a whole thing to deal with, because think about prenatal visits, and you have to go into this facility however many times in your pregnancy, worrying about whether you're going to get infected. So that was big, and I think that seems to kind of stuck with a lot of people, even repeat or families with multiple children who have delivered in the hospital. They just want a different experience. I've had clients who've done all the experiences: hospital birth, birth center birth, and I've done their home birth. So it's just different. It's usually different reasons. Some, it's not a crunchy, hippie thing. It's, people have their reasons. Yeah.
Thank you. I imagine they do. But
Mhm.
I understand. I mean, I had a home birth, and that experience was like, I would always want that, for my other children if I have some more. Um, but yeah, that's good. I hope that that continues to spread throughout the community, and people kind of get the courage to go that route, because it's very different.
Mhm.
It's very,
Oh, and
very
the
different.
reason for not is is that a lot of well, fear is, we are pretty conditioned to think that your labor starts with your water breaking in the grocery store while you're shopping, and you race off to the hospital. So the media plays a big part in how we view birth, and it's not that, y'all. It's really not what everybody's labor starts different. Everybody's pregnancy looks different. You could be terrified in the whole pregnancy and just rock out your home birth, or vice versa. It's just everybody is different. Every situation is different. A lot of people just about 90% of people that call me, like, I want a water birth. So that's a good one. I usually tell them, well, that's a good goal to have, but consider that during labor, the water may be very just not comforting to you too. I've seen that. I thought I wanted a water birth, but I just couldn't. you know. So yeah, there's all kinds of reasons, but water birth is a big one for why people want home births, because that isn't available in the hospital. You can labor in water or maybe shower, but baby coming out in the water is not a thing.
Well, hi, Tiffany. Congratulations on your practice. I think it's awesome. It's a great presentation. Thank you for what you're doing. I had a question that you sort of kind of answered about some of the changes that occurred with practice during COVID, because I know as a former birth worker, I had a lot of young people reaching out to me with the same fears. They didn't want to go to the hospital. They wanted to have their babies at home, and like you said, you were in the process. Had another young lady that at the time was practicing, but she was booked solid. She couldn't take anybody else. I was trying to refer people to her, and they were like, well, you just do it. And I'm like, no, I don't do that anymore. Unless you want to come visit me in jail. But I think, and this ties into what Amandla was saying too about reasons that people are and are not, it's just a knowledge level. Those who I'm seeing a lot of young couples, particularly couples of color, who are taking that power back, that they can have their births at home with each other and with their family. They can be more in control of what's happening during their experience. That was a big thing. Like you said, several of them, I know they had a previous hospital birth and did not like the care that they received from their healthcare providers, either prenatally or during their delivery. And then on the other hand, you have the fear of that, oh, it's this great big mysterious medical procedure that only a doctor can handle. And so that conditioning is something that we have to work on undoing also, this fear of birth. So just empowering families to take their care and their experiences back into their own hands. And so I'm really excited about your practice and what you're doing, and for you to be doing this presentation to present to maybe some people that are not familiar with midwifery care. Kind of all ties in today, because I took off to attend this, but I'm attending the Black Maternal Health conference that Tufts is doing, and it's all about midwifery care and Black maternal health. So this just been a great day for that. So I'm glad that you're bringing this aspect to our local community too, that they can get more experience with this. So
thank you.
Keep up the good work.
Thank you. Thank you.
Are there other questions for Tiffany?
Chat.
Tiffany.
Yes.
I have another one. Give us a little bit of information about the financial aspect of you providing care to someone. Being, I still work, I'm even now working in a rural community. Resources, often can be challenging for a lot of young couples. So I'd like a little more information about that, of how they could maybe navigate.
I am a Medicaid provider. I'm in the process of trying to become in network with all of the MCOs, so we can just kind of eliminate the need for a prior authorization, essentially. I find that that's a little bit of a barrier, or a big barrier for getting care. A lot of people getting care, some people have insurance, they want me as their midwife, but they run into barriers with their insurance companies, and some become so frustrated that they just give up and just have to deal with the OB, but we get very minimal pay, very minimal. And I don't have any cash pay clients. So most of my clients are Medicaid. I've had a few Florida Blue, a few, yeah. So that's that. So I would like to get set up where I can be in network. That therefore anyone that comes to me, if you have insurance, we don't need that prior auth. Let's just get started with care. But that's been a really tough process trying to figure out insurance. It's but I feel like my role as a midwife, I will say, is to be more in the way of policy change for us, simply because it's near impossible to be sustainable as a midwife, and then access to midwives is slim. So yeah, I would love to see some change in our legislation with that. It would be great, but you gotta have that's why you gotta have a passion for it.
Yeah. Thank you.
No problem.
Any other questions?
Well, okay, that brings me back to something else that you just said, and especially what you said about policy. I'm more in the, let me take my sling off my finger, breastfeeding world now. I'm working with the health department in Gadsden County with the WIC program. So now participating more like with Dikebra and Sandy and different ones on the breastfeeding coalitions and looking at policy. Is there a local midwife association or coalition or anything that's working on anything like that?
We have a Midwife Association of Florida.
Right.
That is, I was going to put it in the chat, but I don't want to put the wrong.
I know what you're talking about.
Okay. Yes, where we have a liaison, but I'm not sure. It's the most I know is that we have to pay our person to, you know, to work for us. So I think with that organization is, you know, we struggle. We do struggle with resources and finances to uplift our profession. So, but there is one in Florida. As far as education, there's the Midwifery Education Accreditation Council, MEAC. We're also regulated by NARM, the National
North American
Registry of Midwives. Thank you, Dr. B, and MANA, and also the National Association for Certified Professional Midwives. So those are some of our big kind of regulators. We follow ACOG and American Pediatrics. So we, all of those people help inform us.
But there's no like local or like regional network for midwives? No.
Not that I know of.
All right.
All right, everyone. Any other questions? All right, this was great information today, Tiffany. Thank you so much. And thank you everyone for taking time out of your day on this holiday, Good Friday, to join us today. We'll be sending out this recording, so please share it with community members. I think we need to spread the word about this model of care for our families. Our next Lunch and Learn is scheduled for May 5th. We will be discussing stress and the impact on women during both the prenatal and postpartum period. Our very own Dr. Haynes is going to be presenting for us on that topic. We'll be sending out that flyer along with the recording. I hope you all have a fabulous weekend. You take some time to relax this weekend and enjoy some time with family and friends. Thanks again for joining us, everyone.
Thank you.